Thank you for the kind introduction. My name is Sadia. I am a preventive cardiologist based in Chicago, and I really appreciate Echo and Chris for the kind invitation to spend some time chatting with you guys, thinking about primary care in our defensive strategies for preventing heart failure with a little bit of a play on the prevent equations, which we'll talk about as well. Um, we can advance the slide here. I have no relationships with industry and funding from NHLBI and AHA. Next slide. So I'm going to start with a little bit of a fantastical question. Can you imagine a world free of heart failure? Is it even possible? And I'll argue that even if you don't believe it, and believe you me, there's lots of skepticism around this idea of erasing or completely eradicating heart disease or heart failure, specifically for this talk. But I think we have to aspirationally approach this from that perspective and then see how far we can get. And I think with the right patient, with the right risk tools, with the right for the right patient and the right treatments, we can get at least closer. Next slide. So in order to do that, we're going to talk about three key objectives in the next 19 minutes or so. We'll review the growing burden of heart failure morbidity and mortality, particularly in rural communities. And I heard a lot of different areas of Idaho covered, so I think this will be very relevant. We'll discuss the role of risk prediction in heart failure prevention and the available risk tools that now exist for heart failure. And we'll conclude with strategies for evidence-based prevention of heart failure once we've identified who's at risk. Next slide. Awesome. So getting started with the first category. One of the reasons I was really excited about this topic was that we have almost exclusively focused on preventing MI, and we've done a great job at it. But if we advance the slide, where we're struggling, and I think we need to focus, is heart failure mortality. These are data from National Death Certificate coding for heart failure being included as a cause or contributor to death. And you see around 2011, 2012, there was this reversal where 2012 to 2019, there's been dramatic increases in heart failure mortality overall. And then when you stratify by rural urban areas, you see those curves follow the exact same pattern, but consistently higher in rural areas. Next slide. We also know that heart failure is relapsing. It comes and goes in terms of acute exacerbations. And we see that in our patients who, once they get hospitalized, they have this acute event that makes them decompensated. But the thing that I like about this figure that's really important for heart failure is they don't come back to the same baseline. Our goal, of course, is hopefully to bring people back and recover them and compensate them. But generally, there's a projected decline over time, and that each episode contributes to worse risk. The other aspect of this that I think is really important, and I love this figure that was published a few years ago in JACC, that really highlights when we talk about high risk ASCVD, we're talking about a 7%, 10% annual risk. When we talk about high risk heart failure, we're talking about half of patients being hospitalized, dying in the next 3 to 6 months. And so I think that frame in terms of the absolute magnitude is really important too. Next slide. But heart failure doesn't occur overnight, and this staging system in the universal definition, as well as earlier heart failure guidelines, which were reiterated in the 2022 guidelines, really highlights this opportunity for prevention. So if we think about stage A as the risk factors that we care about, stage B as this pre-heart failure period, well, there's a lot to cover, perhaps decades of opportunity before we get to stage C or symptomatic heart failure or advanced heart failure, when we're really talking about what are the potential opportunities for palliating symptoms at this stage. If we go to the next slide, I think what happens is what we really know is there is a point of no return. Once someone has decompensated heart failure, I often liken that to falling off the cliff. We can get them back to some ability, some stability, but the risk is still quite high. And we don't think we can cure heart failure yet. And so the best opportunity is really prevention in stages A and B. Next slide. But unfortunately, we're facing an ongoing battle with increasing burden of risk factors, overweight, obesity, hypertension, as well as poor control, prediabetes, and diabetes are all increasing and contribute to this burden. Next slide. one of the things that I think is really important as we raise awareness for prevention is that some of this is actually happening in very young adults, people where we often aren't even screening or aren't coming in for routine primary care. So among 20 to 44-year-olds, we see that the rate of obesity in the US has now exceeded 40%. For diabetes, we're past 4%. So these numbers are quite high and they're growing. Next slide. While we know what causes heart failure, one of the challenges is how do we identify who's at risk for heart failure? Because if all of a sudden we're now going to think about this on top of prevention of heart attack and stroke, what are we going to do once we identify those patients? Next slide. I think risk prediction is something that we think about whether subconsciously or consciously every day. It's been a key component of prevention in cardiovascular disease for over 3 decades, but it's largely focused on atherosclerosis. But the premise behind it is really helpful to think about and see how we can apply it now to heart failure. Next slide. The idea being that we want to be able to match the intensity of our preventive efforts to the predicted risk of the individual so we can personalize care. And specifically for heart failure, how do we identify the people that are at highest risk so that we can then identify what are the best therapies for them? Next slide. This was best articulated actually several decades ago. It was actually 30 years ago. Jeffrey Rose wrote this a really interesting viewpoint called sick individuals and sick populations. Now, at the time, there weren't so many safe and effective preventive therapies, so it was even more relevant to say that if this entire Bell diagram is the population, you don't want to expose all of them to drug treatment, especially if those are drugs that are not as safe or don't have as much evidence. But what you would like to do is say, at the tail end, where we have the highest risk people, we want to be able to say, if you give those people drugs, you're going to get the most benefit or the most bang for your buck. And also at the same time, not expose all these other people to treatments that they don't need and don't benefit them. Next slide. A little of a different way to visualize this is say you see 5 patients in one morning. What you really want to know is can you calculate who's that one person or who are the people that are going to be able to be targeted with preventive interventions because they're at increased risk. So it allows you to prioritize the type and intensity of recommendation that you're providing. Next slide. This kind of philosophy or approach has been broadly included and endorsed in CVD guidelines. Cholesterol, we're all very familiar with the latest 2018 guidelines that have done this, the 2019 primary prevention guidelines. And in fact, it was just a few years ago that the heart failure guidelines and the focus of this discussion incorporated risk-based prevention into the guidelines for how we approach heart failure itself in those early stages or stage A and B. Next slide. In order to support those guideline recommendations, a couple of years ago, the American Heart Association led a new science advisory group and published this scientific statement and the development of the Prevent Risk Calculator. And much of the discussion that went into this was to ensure that we were including heart failure as a key outcome because of the data that I shared earlier. Next slide. Here's a great overview of the prevent equations all in one slide. And I like to think of it in 3 big buckets to say if you were to summarize very quickly what these are. The first is the population and what were the cohorts and data points that went into that. The second are the predictors that were included. And the third are the outcomes. So in terms of the population, we wanted to leverage as many resources as we had. And so these included observational cohorts that were just research-based, as well as electronic medical records through Optum and Geisinger. If we advance the slide, what we saw was that this led to a large contemporary sample for the development of the risk equations with over 6 million people. In the second column, you see this infographic that we thought a lot about of what were the predictors that we wanted to include in the risk equations. These include traditional risk factors. So in the base or the core circle are the ones that we know that we have that we measure readily and are available. And then in the outer, we're including additional predictors that may or may not be indicated or available: hemoglobin A1C, UACR, and social determinants of health. Next slide. So the idea here was that we can combine clinical risk factors and new predictors and have a base model or core model with these add-ons. The third bucket is the outcomes that we included, which was really to get at this concept of now incorporating total cardiovascular disease as a composite of atherosclerotic cardiovascular disease and heart failure. And if we advance, this really was intended to highlight the inclusion of a new heart failure outcome so that we're more comprehensively assessing CVD risk. Next slide. How well did this model do? You can see here the two key performance statistics that are displayed are the C statistic, which gives us a rank ordering. And so that really ranges from 0.5, which is the flip of a coin, to 1, which is perfect. And we see a number right in that 0.7 to 0.8 range. So really good to excellent discrimination. The calibration slope sets up this idea of saying if we predict X number of events, how many do we observe? And 1 is perfect. So all of our calibration slopes are right around that 1. So really helpful, especially for heart failure. Next slide. One of the things as we were working through the development was we wanted to make sure that these models also performed well in data sets that were external to how we developed it. And so the VA was a great opportunity to collaborate with investigators and say, how well do these models perform in a high-risk diverse population? And you can see in the first two panels that plot that observed and predicted with that slope of 1, all of those colored dots by race and ethnicity line up around 1. Whereas when you plot the pooled cohort equations, which is what we've traditionally used, you see that tail end, which is suggesting that there's overestimation happening over about a 5% predicted risk. Now, one of the important parts of what we did here was really to pay attention and say, what are the risks and the calibration by race and ethnicity? Because race was not included as a predictor in these equations. Next slide. The calculator is available online. The QR code is here, the URL is here, and one of the things that we're working really hard on right now is to get this integrated into electronic medical records so that it is automated and accessible for use. Next slide. So what do we do with this? Hopefully I've convinced you we need to predict risk of heart failure. We can accurately and precisely predict it with PREVENT, but then what do you do once you have that information? Next slide. In order to help operationalize that, we put together this scientific statement and this Lancet series to start to say, how do we provide a framework that actually allows you to move from risk calculation with an estimate to prevention with the evidence-based therapies that you need? Next slide. So the current guidelines for heart failure risk assessment and prevention include two 2A recommendations. The first is a very general recommendation to say we should calculate risk using multivariable risk scores, and these were published before the PREVENT equations were developed, so it was a more generic recommendation. The second one that I think is important and is less well utilized right now because of a lot of challenges is to consider BNP or NT-proBNP screening and team-based care to prevent the development of LV dysfunction or new onset heart failure. And I don't know about many of you, but we have a really hard time getting BNP covered if someone's asymptomatic. And so it really makes it challenging, even though there's great data on why this might be useful. Next slide. What do we do? Well, I think the most effective and best evidence that we have is lowering blood pressure. And in the SPRINT trial, which of course is the landmark trial of intensive blood pressure lowering that showed in lowering blood pressure to less than 120 was more effective than using a conventional target of less than 140. And you can see that in the intensive treatment versus standard treatment arm. But one thing that I don't think gets enough attention is the outcome was driven by the prevention of heart failure. And the effect on the prevention of heart failure was very dramatic and more impactful than the overall hazard ratio. Next slide. There's growing evidence that lower blood pressure equals lower heart failure risk and lower overall CVD. And we now have 5 different trials for intensive blood pressure lowering in the last decade that tell us how important this is, although super challenging and really hard in terms of getting patients on multiple therapies and getting this blood pressure down. But I'd like to point out that there's two targets that have been studied, less than 130 and actually less than 120. Next slide. And as we think about that, that is what went into the latest blood pressure guidelines with a focus on prevention. And there was a new recommendation that incorporated the prevent equations and used the overall CVD outcome, so ASCVD and heart failure together, saying that when there's an individual where the blood pressure is over 130, the systolic blood pressure, if they have diabetes, CKD, cardiovascular disease, or a prevent score of greater than or equal to 7.5%, treatment with antihypertensive should be started. And then this target, the other new thing in the guideline was while we've been used to saying get to less than 130, there was encouragement to achieve less than 120 now with the growing evidence, and in part because of the great evidence to prevent heart failure. Next slide. We also have a lot of new therapies. A lot of these are inaccessible and expensive, but they do address obesity, diabetes, and CKD, the precursors of heart failure, and therefore heart failure risk. If we advance to the next slide, we see really great outcome data, somewhere between a 15 to 20% reduction in major adverse cardiovascular outcomes. A lot of it is driven by heart failure, especially for the SGLT2 inhibitors and the nonsteroidal MRAs like finerenone, but even benefit in the GLP-1s for that. Next slide. I always like to show a bit of a timeline when I'm talking about risk and guidelines because it's important to know how these crosswalk and talk to each other. Framingham, while older, really informed the ATP3 guidelines. Pooled cohort is currently where we're at with the ACC/AHA guidelines. But now that the prevent equations have been published, we know that over the next 12 months, we're going to see updates for cholesterol and CKM syndrome. And we just got the updated blood pressure guidelines as well. Next slide. Want to conclude with three key takeaways. We looked at data that show the burden of heart failure is increasing with growing burden of antecedent risk factors, particularly in young adults, and these are higher on average in rural areas. The prevent heart failure equations accurately and precisely estimate risk for heart failure and the overall CVD outcome with similar calibration across groups. And lastly, risk prediction enables prevention of heart failure with evidence-based treatment like blood pressure lowering and SGLT2 inhibitors as our tools to help lower and prevent risk of heart failure. I think I have one more slide after this, which is from this great book, Within Reason. I have no royalties or ties to this other than I think this is a great quote. We spend far too much on treating disease after it happens and far too little on preventing it in the first place. By the time illness arrives, we are already too late. Thank you guys for your time and attention, and I really appreciate Echo for inviting me to participate.
Well, thank you so much, Sadia. Incredible talk, distilled really important topics very nicely for us. So as the moderator of this Q&A, I guess I have the privilege of asking the first question, if that's okay. Um, we just our group presented a poster at the European Society of Cardiology on the prevent equations in people living with HIV infection and showed that they very much underpredict risk. So what are some of HIV is one, but what are some of the other populations for whom you think maybe the equations are poorly calibrated in one direction or the other? Either they're under predicting risk or over predicting risk.
Yeah, Krista, thanks. That's a great question. And I'm curious for ASCVD, heart failure, or both, and both seem like they may be relevant considerations depending on where in the stages of HIV treatment and other considerations. But I think it's such an important point about personalizing care, whether we're thinking about HIV or I think a lot about women's health and adverse pregnancy outcomes influencing risk of cardiovascular disease or autoimmune conditions. We know there's a lot of other risk factors that don't go into risk calculators that can influence risk for cardiovascular disease. And I think there, the primary prevention guidelines did a really nice job of this calculate, personalize, reclassify framework of saying the risk equation is meant to be a first step and not the where you stop. And so if you have a risk estimate, but you know there are risk enhancing factors or specific considerations that increase or decrease somebody's risk, then that should help influence or change it. I think LP little a is another great example where we're seeing really important data, where if someone has a very high LP little a, this biomarker, then even though the risk may be estimated at borderline, that might tip you as well. I think for ASCVD, coronary calcium has become the really go-to as like if you are on the fence, it can definitely decide if someone has disease or not. So let's actually measure the burden of disease where we can.
Yeah, that's great. So maybe I can open it up to everyone. Please put questions in this in the chat. But are there any panelists perhaps who would like to build off of what Sadia has presented so far? Ask a question. Brian says yes, BNP blocked by payers as a screen. Uh, we are very interested in that as well. So do you know, Sadia, are there groups, are there health systems that are doing this well, that maybe have decided, well, we'll just invest in making BNP available to screen?
Yeah, I have not seen that. It's an interesting question whether through point of care, the way hemoglobin A1C in clinics with point of care has been much more, it's so much easier to use then, right? Like if you're going to want to adjust somebody's medications, you can get it while you're seeing them. I think it's going to take a lot more from CMS, which will take more from USPSTF or guidelines to really change that before we can start to see it more universally.
Great. Anne has her hand up.
Yeah, thanks. Great presentation. And I have been using the Prevent calculator. You didn't quite touch on it, but tell me a little bit about how the zip codes go into the Prevent calculator and how that was developed and kind of what has been the trend like rural versus urban or certain specific demographics of society that have been built into that.
Yeah, it's a great question, and it's one that comes up a ton when we're thinking about how can we personalize based on what we know are place-based risk factors, particularly across large areas. So the first, I think you hit on it, zip code, right? We're really not getting at that granularity of neighborhood, and I live in Chicago, and there's a 30-year life expectancy gap over an 8-mile radius, and it's all the same zip code. So it's absolutely not perfect, but we wanted to build it in, I think, philosophically as a first step to say we need to be thinking about assessing and addressing social factors. And this was one that was accessible in the data. So we had zip code level information in the electronic medical record that was then crosswalked to the social deprivation index. We decided analytically to do tertiles. And so it's also not so granular that it's the exact decile, to look at the gradient of risk. And so it's very much what you imagine, like we do with any other risk factor, where the people who are in the highest tertile have a slightly higher risk. So it's really just nuancing how much risk there is and starting the conversation about social factors. So I think a lot more to be done, especially about individual level factors, especially the fact that zip code is imperfect in a large geographic area and that it doesn't cover all the other lived experiences that influence risk.
Great. How about younger people and using 30-year risk scores to predict risk?
Yeah, I was super excited to be able to think about this from a longer perspective because we know that age is such a dominant factor when we think about risk factors. I mean, I love thinking about risk calculators, but turns out they don't really help until you're talking about middle age because young people don't have events, even though they're accumulating risk. And so the idea behind being able to scale it to 30 years was to be able to give us a sense of a way to start conversations earlier in life in their 30s and 40s when that risk is accumulating and thinking about ways, whether with lifestyle or medication, that we can treat it. I think the more important question, which I'm somewhat bypassing, is well, what do you do with that information and how high a 30-year risk score is too high that you're going to do something? And that's where I would say, stay tuned for guidelines to help us navigate that.
Yeah, excellent. Any other questions from the audience? Please raise your hand. Sadia, how do you talk to your patients about the importance of diet and lifestyle and exercise in particular as being important for prevention?
Yeah, I think one of the most helpful things that we have in our clinic is a lifestyle and behavioral program to get help with that. And so being able to start the conversation around what are the current strategies and then what is feasible and where people are on their decisional spectrum of wanting to um, uh, participate in change. Structured programs are really helpful. I've had a lot of patients participate in online Weight Watchers as one of the most useful tools. And I think acknowledging it's really hard. And so, how do you build it into a routine? And so, it's really an ongoing conversation. I don't have a easy answer, but I think it's something that we're all trying to come up with a better way to do and also have partners in this.
Yeah, I think that's what everyone is trying here. Anne, another question.
Yeah, sorry. I love that you brought up LP little a and talking about that. It's definitely something in the last couple of years I've been including in my workup in, cardiovascular disease risk assessment and prevention and screening for my patients, and kind of using that as a tool um, to encourage people to try and be a little bit healthier, but just kind of wondering, you know, at what age would you start looking at that? Kind of there are recommendations, from the American Academy of Pediatrics to screen children for cholesterol, in the preteen years, and what we think about that, and whether LP little a at that age is something that you would consider. So, like, what age would you consider starting LP little a, or and then, at that young age, when would you start more than lifestyle interventions?
Yeah, I think I'll answer the second one first because I'm not a pediatric person, so I will defer a little bit on that. I think, it's interesting. I would say actually pediatric preventive cardiologists tend to be more aggressive than adult cardiologists when they're managing young adults. So like they will, I think, get a little bit more intensive with potentially considering statins earlier on. The FH data are really impressive to say how safe it is to start statins earlier, but it is a very challenging conversation to have when you're about lifetime therapy and starting that earlier. So, not a, I don't have a great answer for when to start outside of FH, of course, for treatment. For women in the reproductive years, there's always challenges around intending pregnancy, planning pregnancy, and stopping statins with pregnancy as well. So I think that's another key period and key life period when there may be interruption to therapy, but we don't want to say that during the entire reproductive years, statins should be avoided. Um, you had a first question that I've now forgotten as we talk through the pediatric piece.
Well, just like,
LPA.
yeah, LPA, exactly. Yeah.
LPA has really been a very fascinating story because I think we've seen much more messaging for testing before we have a therapy, as opposed to a lot of other things where we have waited for the trial evidence and then have started the messaging. So I think some of it is it's helpful because it's starting to try to consider what would we do if these therapies are positive. But I would add a little bit of skepticism to say we don't actually have any therapies that are evidence-based that prevent CVD to treat LPA. So I agree with you. I use it more to help classify risk if I have a person with a known family history of premature CAD and it would change their management where I'm not already giving them intensive lipid lowering or overall prevention.
This has been great. Lindsay, I think we're aiming to wrap up around five after. Should we see if there are any last questions? Oh, Aradna has something in the chat here. On that note, consideration around adding family history to the prevent equation.
Yeah, we talked a lot about this, and I actually do cardiovascular genetics in my preventive clinic. So I talk with people very extensively about a three-generation family history. And it's really time intensive, right? And it's really challenging, and most people don't know very much about their family history. So I would say there's two challenges in risk modeling around adding family history. One is having that data available in a way that is granular and accurate. And then the second is how well can you integrate that in large data sets where it's uniformly collected and ascertained. And so those were the challenges that precluded us from using it, but absolutely super important. And I often will include it as the same way I do with someone has HIV or has had an adverse pregnancy outcome and in talking through and thinking about if it increases someone's risk.
Excellent. Well, thank you so much, Sadiya. I'll turn it over to Lindsay now. Can I say maybe a few words before we move on to the case?
Yes, please. Thanks, Chris.
I just wanted to put in a plug for the smaller quality improvement cohort for those of you who are interested in working within your own panel of patients to improve guideline-directed medical therapy for your patients living with heart failure and reduced ejection fraction. This opportunity is going to be great. We'll get together and discuss strategies and challenges in getting GDMT titrated to goal. In particular, if there's anyone from the Kootenai Health System or the Terry Riley clinics in Boise who are participating in other aspects of our AHA-funded work, we'd really love for you to join because we'll be specifically looking at GDMT prescription rates in your clinic populations as part of this larger AHA project. Thank you again, Sadiya.